Hello, the language of COVID. But before we do that, I have a couple of housekeeping details. First of all, please use the Q&A function here within the Zoom function. The hand raising doesn't work, but the Q&A does. There's a PDF of the slides available in the handout section before you enter this session. There is also a discussion tab that's available outside the Zoom session where you can post other comments or questions. So let's get started. So the title of this afternoon's talk is The Language of COVID-19, What's Gone Wrong and How We Do Better. I'm going to be reviewing different messages and pieces of information that have been publicly available about COVID-19 and looking at that in the context of different risk communication and health literacy concepts and principles in terms of how that communication has gone. The learning objectives for this afternoon are to look at the features of effective risk communication messages, to look at 3 ways that COVID-19 information has not followed those effective or match those effective features, and then to describe 2 actions that health literacy practitioners can take to improve COVID-19 or really any information related to health risks. So we know that the information environment for COVID-19 has been very complex even from the beginning. We're seeing that people have become very afraid of the virus. There's a lot of confusion and disbelief. A lot of people saying, I don't know who or what to believe and throwing up their hands. We see that that's feeding increased distrust of authoritative and official sources. We've had people recommending fake or harmful remedies, which has also served to confuse people about what are the most appropriate protective behaviors. And then we've had scapegoating of different groups in terms of responsibility for why this is happening and what's gone wrong. And so in general, we have a mess of an information environment. And what we're trying to do is figure out ways to effectively get through to people with positive health behavior messages that can help them protect and promote their health in this very trying time. So when you're thinking about risk communication, the essence of that is effectively, successfully conveying what the risk is and then the actions that people can take. This is the core work that we have as communicators during any crisis or emergency event. If we are not communicating in a way that helps people feel more confident and more prepared, then our risk communication efforts are failing. Because these are, in health literacy work, we always talk about people being under stress or having an emotional reaction to different kinds of health information. But during crisis and emergency events, these features really get amplified and have important effects on the way that people look for and process information. So we're going to be looking at some of the ways in which this has not gone well for the last 6 months and how we could apply these frameworks to do better. Because at the end of the day, that's what we want, is we want people to feel more confident, more prepared, more ready to act to protect their own best interests. So I want to look at some things that have really contributed to making this what I think of as a dangerous risk communication environment. So I'm going to look at a number of elements here before we talk about the risk communication framework. So in thinking about how to organize the talk today, I looked back at what were the initial public information statements about the coronavirus initially, and then it switched over to being referred to as COVID-19. And at least in terms of 2020, the first reference I found in leading media in this country was the New York Times on January 8th, 2020, where there was a story that was referring to the World Health Organization statements about the Chinese government's response to the outbreak. And there's a statement from the WHO representative to China about this situation. And the statement was very reassuring that the Chinese government had things under control and there was no need really to recommend any restrictions on trade or travel because of this virus. So there was a very sort of reassuring tone to this message that things were under control. But at the same time, we will see that there were some other messages indicating that leading experts did not really know what this situation was about. So, and the same time, on the same January 8th timeframe, we saw that reporters were stating in their own words that there was no evidence that the new virus is readily spread by humans, which would make it particularly dangerous, and it had not been tied to any deaths. But health officials in China and elsewhere are watching it carefully to ensure that the outbreak does not develop into something more severe. When we look at the risk communication framework, we will see why this kind of statement is so problematic. To frame it, first of all, in passive voice, there is no evidence. But second of all, to state it so definitively in terms of there being no evidence that the new virus is readily spread by humans. Because at this point, it was still being framed as a novel virus, which meant that they really did not know what many of its core characteristics were. At the same time, in the same time frame, these were the kinds of photos that were available. This one is from the Associated Press, and it was a picture of health surveillance officials in the Hong Kong International Airport, looking fairly casual and relaxed, no sense of panic or dismay. In this photo, just that they were monitoring and watching the situation. Again, very consistent with the description that things were under control and that people were alert, but no need for alarm yet. 2 days later, however, the first death was reported, and this was the photo that was in the January 10th New York Times online edition. And we see suddenly people in these hazmat suits. We see them in a laboratory environment, even if we don't know what a BL3 refers to. You've got that biohazard label there. A very different, feeling is being conveyed by this image in comparison to the one that we just saw 2 days prior. And in this same time frame, this was another photo distributed through Getty Images. Of a man laying in the street. Again, people dressed in this hazard gear. Very little context other than this does not look normal to us, right? This is not what we are used to seeing. And again, an image of an empty street, no real movement, no people, obviously something very different from what we would normally expect to see with an image like this. So in this matter of a few weeks, we've gone from a situation where everything's kind of under control, there's no human-to-human transmission, there's no evidence of that, to these kind of very disturbing pictures of people in hazmat suits and empty streets and someone laying in a public street with people dressed in this strange garb standing around. So a few days later, on January 17th, again in the New York Times, we have official spokespeople from the Centers for Disease Control and Prevention in the United States making some observations about the situation. So we have Nancy Messonnier, who is the director of the National Center for Immunization and Respiratory Diseases, being quoted as saying at a news briefing that this is a serious situation and we know it is crucial to be proactive and prepared. But she continued that while there will probably be cases in the US at some point, quote, we believe the current risk from the virus to the general public is low. The underline added by me, but you will see if you go back and look in this time frame in January, low is the most commonly used word to describe the risk to the American public. 2 weeks later, there was a CDC press release from the CDC director, Dr. Robert Redfield, who said, we understand this may be concerning, but based on what we know now, we still believe the immediate risk to the American public is low. So in the January 30th timeframe, that may have been technically true that the immediate risk to the American public was low, but in hindsight, we know that the virus had already been circulating in the United States at that point, and that this lead up to January 30th and this pronouncement that what we know now, the immediate risk is low, basically was setting the public's mental model for how to respond to this advice, to the situation and to the virus. We're going to turn next to the crisis and emergency risk communication framework. And what we know from that framework is that it was developed to really help frame the initial response to a crisis or emergency event. And the reason that initial response period is so important is because that's really setting the tone. It's giving people that mental model or that framework for how to think about what this event is. So that in this look back across this whole month of January, the message that we've been getting is verbally people are saying things are under control, the risk is low to the American public, but yet we're starting to see some kind of disturbing images, not in the United States, other places, but still some images that kind of let us know that things are a little bit out of place. The last element that I want to look at, again, in the same time frame, is that we were seeing a lot of comparisons. And we know that one of the techniques that is often offered to help people with understanding is metaphors and comparisons, this idea that something more familiar might anchor people's thinking and help them think more concretely about things. So we saw many, many people in this time frame make remarks about the seasonal flu or seasonal influenza. So this is just one quote that I found in an LA Times op-ed on January 29th by a physician who said, "I wish I could convince someone walking down the street in Los Angeles today that he or she is 1,000,000 times more likely to encounter the flu virus than the new coronavirus. But I know that the emotional center, the hardwiring of the brain, is too strong, fed as it is by news-stoked fears." So if someone is feeling afraid or feeling at all worried about this new coronavirus, he's attributing it just to the media sort of feeding and perpetuating these fears, rather than a legitimate concern to something that is unknown to humans. That's what a novel coronavirus or new coronavirus is. So this comparison to the flu happened many, many times by many official and authoritative sources. There were also comparisons to other coronaviruses known as SARS and MERS, with the idea that, again, it was supposed to be giving people this more accurate picture of what the risk was, that they were still in the January timeframe more likely to encounter the seasonal flu than this new coronavirus. But at the same time, admittedly, the officials knew very little about this virus. They did not know that there was community spread. They did not know how humans were going to be affected. It was still very, very early in the outbreak to make any of these sort of firm decisions about how people would or would not be affected. So we know that this comparison to the seasonal flu has continued to be problematic in terms of people using it as a reason to kind of dismiss or at least minimize certain recommended protective actions related to COVID-19. So now I'm going to turn to this model that was developed it was developed through academic research and a lot of practical experience, but CDC kind of codified it as something called the CIRC model, Crisis and Emergency Risk Communication. And there's sort of two mottos when it comes to CIRC. First, that you are focused on delivering the right message at the right time from the right person in order to save lives, right? So this notion that the information that you give people, the timing of when you give it, and who's delivering that message can be quite important in terms of the credibility, the believability, the trustworthiness of that information. And also that it's really important to get out there quickly, right? We know from prior experience, the longer we wait, the more concerned people can get, the more they start to fill in with information that they might already have, which may or may not be accurate, or they may be getting from very untrustworthy sources. So being out there early, being right, making sure that you're not offering incorrect information or partially accurate information that you then have to walk back and correct because that becomes confusing to people, and to constantly think about about maintaining your credibility. So I'd like you to keep these two thoughts in mind as we consider the ways that COVID-19 has been messaged to the public. So there's a number of really important tips that the CIRC model has. Consistency, of course, is a very important attribute of helping people understand what they need to do. To not be over reassuring, right? Especially when there's something that scientists and medical experts may not have seen before or may not be sure about how humans might respond to. Acknowledging uncertainty, right? Especially in the initial hours of any crisis or emergency event, uncertainty can be extreme. In the case of the coronavirus and COVID-19, we know that uncertainty continues to stay quite high. This is not something that's, I mean, there's some types of uncertainty that have decreased a little bit, but there's still a lot of uncertainty about who will be affected and to what extent. Another tip is to say something like, I wish I had answers, to express this notion that you would like to be able to respond to a question, but you may not always have answers in the time frame that people are looking for. Give people a way to find those answers. If you don't have them, there may be other places they can go, or you tell them the time frame in which you will get back to them with those answers, what's going on in order to get answers to them, right? Really help them understand what's involved in trying to answer their questions. Acknowledging people's fear. We know that fear has been at sometimes quite high in relation to the coronavirus and COVID-19. Again, because of the high level of uncertainty associated with this. And similar to what we do in health literacy work, we try and give people things to do. We focus on the actions they can take because that will, again, help reduce their fear. It will help ground them in, practical things that can help them see their way forward in terms of these protective actions. And then finally, ask people to share the risk because there may be things that the authorities, those in charge of the response actually can't do, that it's up to us as individuals to actually follow through. And we've seen that, with face coverings in particular, that in the beginning, it was really framed in terms of what healthcare facilities are going to do. And now the balance has really shifted to what we as the broader community can do in partnership with healthcare and the official government agencies working on the response. So when you think about crafting a message, a risk communication message from this perspective, one of the most important things you can do is to empathize with people, to recognize how difficult the situation is, how much uncertainty there may be, that they may be feeling fear or anxiety, or just really, concerned about the situation. So it's very important to begin your message with being empathetic. Tell people what you know. In reviewing some of those statements from early January, there were some strong statements about what people thought they knew, but not necessarily what actually was known about the coronavirus in that time frame. So it's really important to stick to what you actually know about the situation. And then be clear about what you don't know. This is often very challenging for organizations. They don't like to admit what they don't know. Experts don't like to admit what they don't know. They prefer to focus on what they do know. But really, you help build trust with people when you are clear about what you don't know and the process that you're following to help get those answers for them. So what you're doing to find out helps reassure people that you're aware of the severity of the situation, you're aware of what their concerns are, and that you're taking steps to get them answers. In some cases, there may be important reasons, like for example, like for an environmental accident or for, bioterrorism events and other things, how and why the event happened may be very important. There's been a lot of controversy about that issue in terms of the COVID-19 response. So it would be interesting to get people's reaction to how important you think that's been in terms of influencing the message. And again, providing those action steps is critical. That's one way that you help reduce people's fear. You help build their sense of control over the situation. And we know having a sense of control is really important to helping people have a healthier emotional response. And then finally, express your commitment to follow through, to do what's necessary to take action. So these are the kinds of things we're going to be looking at then and considering in terms of how the COVID-19 messaging has unfolded. I think health literacy adds some additional factors to what the CIRC framework lays out. In health literacy, we're extremely focused on being clear. You'll notice that that really wasn't a feature of any of those kind of checklist items within the CIRC framework. Certainly it's implied, but I think in health literacy, we make that a priority to make sure that we are being as clear as possible. We also try and use familiar language, use familiar references, use familiar faces when we're trying to think about the best ways to prepare and deliver information. So really emphasizing what's familiar to people, again, that will give them a sense of comfort and help them anchor that in, anchor what you're telling them in what they know. Being very precise in our language. Sometimes that's kind of a characteristic that's more associated with scientific communication, but I would argue after many, many years of working with plain language that precision is a hallmark of using plain language techniques well, is that plain language really forces you to think very carefully about what you're saying. So I would argue that when you are doing health literacy work well, you are actually being very, very precise in your language. And finally, health literacy, reminds us to think about numeracy as an issue. And we'll take a look at a couple of examples of how numbers have been used in the COVID-19 response. So let's take a look at some different examples about how well COVID-19 language that's been publicly available matches up with these best practices for CIRC and health literacy that I have just laid out. So example number one, we know in that very early time frame, the virus was referred to as the novel coronavirus. And in some of those public statements I showed you from January, there was some acknowledgement about people's concerns and fears, right? There was a statement that says, we can understand why this is concerning, or we recognize that people may have a lot of questions or want to know more. So from the perspective of, using an empathetic approach and recognizing people's fears, we did see a little bit of that in that early time frame. But what we did not see much of is really how much uncertainty there was around this. I put novel in italics here because while that was the sort of official name of the virus in the beginning, it also should have been a real clue about how cautious we needed to be in terms of talking about what the virus was and how humans might be affected. The extreme uncertainty and how many things were not known about how this virus might affect people should have been a hallmark of what we were seeing in terms of that public information in that very early period. Certainly, we should not have been seeing statements about there is no evidence of human-to-human transmission, or that just these constant reassurance that the risk was low, because all of those things were very unknown. But yet we were seeing many, many sources really offering this reassurance that they knew more than they actually did. We should have avoided these early flu comparisons, right? I understand that people were very concerned still about getting people vaccinated for the flu because they thought there was still a pretty high risk from that. But at the same time, that really led people to have a very different mental model of what the nature of the risk might be. We know that flu vaccinations are quite low compared to what the public health goals are. That people are often highly dismissive of what the flu is and how dangerous the flu is. There were some very early comparisons of the annual number of deaths from flu, and we know as a society we've been more than willing to tolerate that number of deaths for quite a long time, even though vaccines have been available. So this flu comparison really, I think, sort of put people off on the wrong direction in terms of thinking about how risky the coronavirus might turn out to be. And finally, we saw very little evidence that the official sources were talking about how this would very much be a situation of learning as you go, that we would be constantly getting new information. We would be regularly updating what we knew about the novel coronavirus. And that people needed to expect that there would be frequent adjustments to what our knowledge base was for the coronavirus. We saw a lot of vague descriptors, and in health literacy, we know vagueness is a real problem when it comes to helping people develop a firm understanding of what's being communicated. And these vague terms ended up distorting in many ways people's risk assessments. We saw the reference to people being at low risk. And there's quite a bit of research that says when you use terms like low or high or medium or large or small, that people can attribute very different quantities to those kinds of terms. So what might be low to me might be high to you if we actually were using a number to describe that, or vice versa. So by using the phrase low risk consistently, we give people a very imprecise understanding of exactly what the nature of the risk is. You also saw in this early period references to mild, moderate, and severe symptoms, or mild, moderate, severe illness. I repeatedly saw, posters and fact sheets and flyers and web pages that were talking about the majority of people having mild or moderate symptoms with no explanation of what these mild or moderate symptoms were. How would I know if I had mild symptoms, or how would I know if I had moderate? What we saw were people being hospitalized. We saw people in nursing homes and other congregate facilities that looked under very extreme circumstances. We were left to kind of determine that those were people who were experiencing the severe symptoms, but we still didn't really know what constituted mild or moderate symptoms, or even mild or moderate illness. So again, these vague descriptors left it really to us to kind of fill in the details of what that might be. And that could result in people either underestimating the risk, which we saw a lot of through March and even into April, or to a lesser extent, people overestimating the risk. We saw this phrase of limited person-to-person spread, again, without much definition. What does limited mean? It's a very standard sort of phrase in public health language, but what does it mean to say limited? Is that one person, two persons, 5 people? A small crowd? What does limited person-to-person spread? And the reason that's important is because if you know that if it's a matter of just being exposed to one other person, you're going to have a different sense of what that risk is than if limited person-to-person spread means if you're in a very large crowd, the chances of you actually running into somebody with symptoms or an illness would be quite low. Again, this is based on sort of a vague sense of what the actual probabilities might be, but without providing the actual numerical data to help people understand those probabilities. And finally, we saw another example of this vague descriptor. It was close contacts. What did close mean? How close did I have to be? Was that somebody that I was emotionally close to, physically close to? Was it a matter of inches or feet? It took quite a while for people to really understand what close contact meant, even though that phrase was being used pretty much from the beginning in terms of telling people to avoid close contacts. Another example of the kind of language that really was showing up mainly in terms of numerical information was this focus on the infection, the numbers of infections and the number of deaths related to COVID-19. So the numbers of infections and the numbers of deaths have pretty much been the lead on most public information for quite some time now. With the underlying assumption that when you tell people these numbers, that somehow this will be personally informative to them and motivational. So that, for example, if I know that 72,000 people have died from a particular thing, that should sound like a lot to me. And so if it's a lot, then that's somehow going to inform or motivate what my behavior would be, because I think that's too many and that therefore I might personally be at risk. There's a lot of assumptions built into using these numbers in that way to try and be informative and motivational. I think we saw, though, that we many weeks ago blew by the number of 100,000 deaths here in the United States, and we did not see much change in behavior. So I think it's fairly straightforward to say that you know, we should be putting to rest this notion that just reporting these large numbers in you know, by themselves are indeed going to help people understand what their personal risk might be. We've seen the estimates about the number of people who might become infected or die from COVID-19. Those estimates have varied widely and wildly. And sometimes they've come with appropriate caveats that, for example, what the assumptions are for the models. But really modeling the spread of the virus, modeling the potential deaths has, you know, there have been many, many models out there, and sometimes it's not always been clear about the fact that they are models, that these are estimates, and that they're going to constantly change depending on what the assumptions are being used for those models. And what kind of data are available to build those models. And finally, in terms of numbers, we saw you know, references pretty frequently to the number of annual flu deaths, seasonal flu. And for, again, you know, we as a society tolerate you know, a fairly large number of people dying from seasonal flu every year. And that has not been motivational in terms of changing people's behavior to get the seasonal flu vaccine. And so in a way, that number served to kind of desensitize people to say, well, okay, it's not going to be so bad then, right? You know, if that many people died from the flu, then, you know, maybe this coronavirus isn't going to be so bad. So I saw that there are a couple of questions. I'm just going to quickly check the Q&A. One question was, did these communication mistakes occur due to a lack of leadership from our health organizations? Possibly. I would say leadership has in general been kind of the quality of leadership or lack thereof of leadership has kind of been a defining feature of this response. We do have historical examples in which we have had stronger and more consistent and effective leadership in which, you know, events that could have taken a more dire turn did not. So yes, I would say that leadership is always a factor in any crisis or emergency response. There's another question about, do I think the ineffective infection rates reported in New York and New Jersey gave people in other states a sense of security? I'm not sure about what ineffective infection rates are, but it may be that early on there was this intense focus on things being so bad in New York and New Jersey, and that other places really, because they were not so bad, that may have given people a sense that you know, they were in far less danger than they really were, because at that point, you know, there was community spread. And we saw in those very early statements, there was this recognition, this kind of very gentle recognition that community spread was going to be likely, but we just didn't know how bad. And so to kind of give people that reassurance that, you know, it's either New York and New Jersey or you're fine. Again, those are sort of extremes that, you know, we knew would not really hold up over time. Let's see. So probabilities are often a feature of this kind of risk information. In fact, you know, the fundamental definition of risk is really about providing people probabilistic information. So very early projections talked about this 80% of people having mild or moderate illness. And I've already talked about why using these very vague descriptions of mild and moderate were problematic. But again, what we know is that the average person does not have a lot of ability to understand what decimals, fractions, and percentages represent. What they do is they look at the size of the number as a clue for their level of concern. And so 80% sounds like a lot. I have to say that when I heard that, I thought, okay, that sounds like, you know, something that probably is not going to be so worrisome. But what we know when we use probabilities or numbers in this way is that there's a factor called denominator neglect, or what I was talking about in terms of large number effects. People really use the size of a number as a clue to how worried they should be. They also don't know what a denominator is for the most part, and they don't know how to figure out what the denominator might be, right? And so to say that 80% of mild or moderate illness means you have to know what the denominator is in terms of both number of people who could be exposed and number of people who were exposed. The phrase of underlying conditions has kind of been a feature of this, of the coronavirus and COVID information from the beginning. We were told that people with underlying conditions were potentially more at risk of this severe illness, again, undefined in terms of what severe might mean, but that people who had certain underlying conditions, and I had people emailing me saying, asking, what's an underlying condition? What conditions are they talking about? You know, what are you hearing? People were very uncertain about what these underlying conditions represented, but yet this was supposed to be an important clue to help us understand what was the likelihood that we might be in a higher risk category, right? If we had one of these, quote, underlying conditions, we were supposed to have a heightened sense of concern because the odds, the chances, the probabilities were such that we might actually have a worse experience with the virus. And finally, these projections of the 80% mild and moderate illness, again, because of the way that numbers operate in people's cognitive processing, is that it was the basis for many groups to minimize or say that things were probably not going to be as severe as what some of the experts were saying. So again, probabilities should be offering people concrete, factual information to help them make those informed decisions about what is the nature of the risk. And what we've seen is that when we've used numbers so far in the COVID response is that they've actually ended up being sort of more confusing than helpful. No presentation at a health literacy conference would be complete if we didn't say a little bit about jargon. I'm going to turn on my light here. I'm sitting here and it's getting quite thunderstormy looking outside. I don't know if that actually probably doesn't help. So I guess I will leave my light off. So it's getting quite dark outside my window. So some examples of the kind of jargon that we've seen in the communication response. Underlying condition, of course, respiratory droplets, airborne transmission, inhaled, asymptomatic, pre-symptomatic, flattening the curve, and social distancing. All of these are phrases that were not in people's sort of everyday vocabulary, probably 2 months ago, let alone 6 months or even longer. So this notion that we can talk about what the nature of the risk is from the coronavirus and COVID-19 using this kind of language is highly problematic, right? So even within scientific circles, there's been heated discussions about asymptomatic and pre-symptomatic, between respiratory droplets and airborne transmission. What is the nature, what is the difference between those two things? Is somebody who is asymptomatic able of spreading the virus or not? All of these things matter in terms of people's understanding of what is the seriousness of the situation, how worried do they need to be, and what kinds of protective actions they need to take. So these are all ways, particularly in which health literacy professionals can have a really important role in insisting that this kind of language is not helpful early on or even later in the response. To count on people learning this kind of language and to use it easily and with complete understanding is just really is not realistic. So this is definitely jargon that needs to go. I noticed there was another couple of questions, so let me see. With such misinformation out there, who should we trust? What are the most trustworthy, reliable sources, federal, state, and local? And what are some challenges with risk communication? Well, I think this whole presentation is really talking about the challenges with risk communication. So if you have something a little more specific than that, I'll be happy to try and address that. But really what I'm trying to lay out are many of the challenges that we've been facing since this. So in terms of the misinformation, I thought a lot about the misinformation question when working on this presentation, because it has been such a hallmark of this particular information environment. And I thought that for this presentation, I really wanted to stick with what were sources that were considered the go-to sources, the ones that we should be relying on, the ones that we were supposed to be treating as trustworthy, the ones where people were being routinely sent for information. Not to say, obviously, misinformation, disinformation, those have been extremely important factors in the response. But I think it's even more problematic when we have the sources that we need and want to trust also providing confusing information that does not help us really understand the nature of the risk. So I've really, in this presentation, I intentionally focused on the official sources and really would have to kind of do a different presentation to really deal with both intentional and unintentional, but largely intentional misinformation problems that have kind of plagued their response. Okay. So somebody said, who should we trust? This was a page that I took from the Centers for Disease Control Prevention about mid-February when I did a presentation here in College Park. And this was what was available on the website at the time. Very typical to start with a definition. What is a novel coronavirus? Why is the disease causing the outbreak? What is the name of the virus, right? Again, maybe this is, important information for those really trying to get into the details. Maybe somebody who's looking to write a report on this, or a reporter looking for background information. But again, from a health literacy perspective, we're trying to quickly and easily get people to useful information that they can apply to understand their situation and make an informed decision. So again, not too helpful to say that a novel coronavirus is a new coronavirus that has not been previously identified. As I've tried to lay out here in this presentation, the main reason to tell people that there was a new coronavirus was to emphasize how much we did not know about what this virus was, how it was going to behave with humans, and what we could expect. If we had been very clear and direct about novelty being an important part of our understanding of the response, then I think that could have been helpful. But just to lead off in terms of defining novel as new, again, not so helpful. So the information has certainly evolved over time, but if you think about what people were looking for back in early to mid-February, this would not have given them sort of much actionable information about their personal threat and how concerned they should be. So let's talk about what health literacy practitioners can do given this situation that we've seen. We have these frameworks, we know these best practices. We've seen, I would say, arguably most, if not all, those best practices violated pretty consistently for the last 6 months. But I do think that there are still things we can do. I think they will be harder. They will be, we'll have to work more diligently to make them effective because we're now swimming upstream, so to speak. We've had 6 months of creating a very difficult and challenging information environment in which people are feeling pretty worn out and distrustful of what's happened so far. But I don't think we should give up entirely. I do think there's some really important things that we can do to help explain the nature of the risk still. So we have many, many ways to communicate with the public, right? We often fall back on text, right? Web pages, flyers, handouts, brochures, but we have numbers, right? And we could do a much more effective job with the way that we use numbers. The literature on how to use numbers well is quite large, and there are a number of tools out there to effectively convey numbers. We have photos and drawings, right? We know that visual images are quite powerful in our current information environment. We have our words that we speak. We can deliver information orally, right? We can record videos. We can, give, well, we used to be able to give talks in person, not so much anymore, but we do have ways of orally communicating information that can make information more accessible to people. Sometimes it is necessary to provide graphs, tables, and forms. That is the most effective way to convey a lot of information in a condensed format. Again, we have videos that we can provide, and we have animations. I'm currently exploring some ways that we could potentially use animations to communicate with college students under the assumption that they want information that is short, quick, entertaining, and easily digestible. So I think we need to think about the full range of tools that are available to us to communicate. So I wanted to just show you a few quick examples. So the New York Times and the Washington Post in the beginning were using a lot of interactive graphics. So hopefully this will work. So this was a 3D simulation that showed up in the New York Times about why social distancing is so important. And what I wanted to show you about this is that even though there are words scrolling up the right side of the screen, that really you could get most of the key information you need just from the graphic itself. You don't have to really read the words about droplets and airborne transmission and things like that, because you can very easily see what's happening in terms of the spray from one person to another. And this is, this is obviously a very highly stylized and high production value kind of graphic, but we could come up with something similar. We could come up with something similar, probably with, the other resources that we have. I want to show you just a quick video. I know that there's many hand washing videos out there, but this is just a quick little 30-second one.
First you need soap, then scrub for 20 seconds. If you don't have a cloth near you,
It's not showing on your screen. It may be on your
screen, sure to scrub from your back, under your fingernails, and between your fingers. Dry your hands with a clean towel or a paper towel. For more information, go to www.
And then lastly, I want to show you this. That's that same wash your hands information, but in the form of a GIF. So there are obviously many, many options for conveying some of this very basic information that we know we need to get out to people. You know, again, we tend to think in text, we tend to think in sort of the traditional poster, flyer, web page kind of format. But I just wanted to give you a sense of just some of the things that have been popping up that are using visual imagery, you know, in a much more creative way. Ways that we can apply, you know, a health literacy tool, the CDC Clear Communication Index. So this was a tool that a colleague and I developed when I worked at CDC, doing plain language and health literacy work. And what we know is that we really need to kind of take health information and communication seriously. We need to make it a priority. And I know organizations have said that they do, but they really have to prioritize that and make sure that the risk communication that they're doing is following these best practices that I've talked about. So I want to talk about 3 items that are specifically in the index that would help us do a better job in conveying risk. So index item number 11 refers back to that CIRC framework in terms of what we know and what we don't know about a situation. So I'm proposing a what if. What if we had originally talked to people about the virus in this way? This virus is new to people and we don't know anything definite yet about how it will affect us. We are collecting information about people who get sick and will update you in 2 days. So there are many hallmarks of what I talked about in both the CIRC and the health literacy frameworks here in this, you know, hypothetical example, right? I'm using new in a way to give people valuable information, right? I'm being cautious and circumspect in how and what I'm telling people that we know. I'm giving them that process information that we're collecting information and we will get back with them in a specific time period in the next 2 days. Index item number 11 says we need to tell people what is the actual nature of the risk so they can evaluate for themselves what they need to be doing. So again, this is a hypothetical example of what we could have said. We think people who have diabetes and heart disease may get more sick from the virus than other people. We are collecting information and will report back next week. Again, we're couching it in terms of the fact this is initially what we're seeing. It's not definitive. We still need more information, but we want to get this out to you because we want you to know that if you have diabetes and heart disease, as opposed to an underlying health condition, right, which was very non-specific, this is something that you might need to pay special attention to. And the last index item that's related to risk communication specifically that I want to call out is item number 19. It says when you give people recommended actions, you need to talk to them about the risks and the benefits. So again, this is a hypothetical statement that we could have used. We talked about social or physical distancing, but staying 6 feet apart from people, even our family and friends, and wearing a face covering may be difficult and uncomfortable, right? Acknowledging this is not what people would choose to do, but it's important to do. But these are the best ways not to get or spread the virus, right? You've got to acknowledge people don't want to do some of the things that we're asking. If you think about just even 5 months ago, we're being asked to do things that we'd never contemplated before. And we have to acknowledge these are challenging behaviors, they're new behaviors, people might not feel comfortable, they might not choose to do this. But yet it's important, if these are what we're trying to do, is make sure that we ourselves don't get sick or other people that we care about don't get sick. So what am I asking you to do? As a health literacy expert, a professional, I'm asking you to do 3 things. I'm asking you to insist on everyday concrete language in the when we are talking about these kinds of crisis and emergency events. That kind of language is going to be most helpful to people. I've given you several examples of the way we've talked about coronavirus and COVID-19 that have really just been too vague, too unknown, too outside people's everyday experience to really be helpful in terms of informing them about the virus. I've also tried to show you that it's really important to help people understand what their personal risks and actions are. They need to know what to do. And if we don't help guide them to that, they will fill in with what they know or what they can find that is easily understandable. And I hope I've convinced you that it's extremely important to be very cautious in terms of saying what is known about a particular situation, particularly when you're going to append the term novel or new to something. If you're going to call something novel or new, then that calls for, as people like to say, an abundance of caution in terms of what we're willing to say the nature of the risk is. So I added this slide as I was kind of sending them into IHA, because I just wanted to remind people about how the advice has changed just in the short period of time we've been doing this response, and how it will continue to change, right? We went from, no masks to yes, sometimes masks, and yeah, masks all the time. We went from no, you can't get this through what's called airborne transmission. It was only through those respiratory droplets, but now yes, through airborne transmission. So this is why we now need to be very cautious about being indoors for prolonged periods of time around lots of other people, right? So what we know about this situation, about this virus, it will continue to change. What we know today is not what we will know tomorrow or next week or the next month. And that we really just need to keep that foremost in the way that we think about communicating anything about the coronavirus or COVID-19. So I noticed there were a couple more questions that popped up here. It says WHO offers a Mythbusters page on their website. Do I have a comment about their website and the information that WHO provides? Actually, I'm not going to comment on that because I haven't looked at that recently. I looked at it a while ago, but I would want to refresh my memory before I comment on that. It says, are there other nonprofits that are doing more culturally sensitive infographics, not just translations? I can only speak locally. Like, so for example, in the area that I'm in here in Southern Maryland, there are local organizations that are creating their own materials. So for example, there's a local clinic called La Clínica del Pueblo that has done their own materials in English and Spanish and posted them on their website. There are other organizations doing something similar. I haven't looked recently at their website, but I do know someone saying, yes, the Navajo Hopi Relief are doing some comics for their population translated into Navajo. I do know that Rima Rudd, my colleague, has frequently recommended, I think it's the Hesperian Society, that provides many materials in many different languages. So if somebody knows that resource and wants to put that in the Q&A box or look that up quickly. But they, in the past, they have typically provided health information in many for many different health conditions. So the last one says, can I provide the links to my video, GIF, and infographic examples? We were unable to see them. Oh, that's too bad. Well, that was not helpful then. But they are embedded in the PowerPoint. So I'm hoping that if you download the slides from the session, you will be able to see those infographics. So it was hesperian.org. I think somebody posted in the Q&A box there. So I'm sorry if you did not see those. I was seeing those and I thought that you could too. So I know that we are at the end of our time. But there's, I think we, yes, Hesperian Health Guides, hesperian.org, more than 30 languages. So yeah, thank you for pulling that up. So I don't see any other Q&A. I just want to provide you some resources. So again, if you download the slides for this session, you will see that there's a number of resources that you can go to for more information. And the full list of items for the Clear Communication Index are available from cdc.gov/ccindex. So thank you very much for your time and attention. And that concludes my presentation.